Good morning, and thank you for the opportunity to present our work. So we're going to switch gears here and get away from the operating room and the robot and get down to the cellular level to look at some of the work that we've been doing in pancreas cancer. And I would argue that, we've really perfected the operation. We can do it safely. We can do it with low morbidity, mortality. We can do it with small incisions. We can send the patient home from the hospital with a short length of stay. But the harsh reality is that 95% of patients with pancreas cancer are dead within 5 years, and most of them are actually die even prior to that. And so we really have to look at novel ways to treat this disease. So I think that the topic of this hour and a half meeting this morning is innovation, and I think that probably the most important innovation in cancer in the last 5 years or so is the emergence of immune therapy as an effective treatment. And the reason why, despite the fact that we've been studying immune therapies for really a century, over the last 5 years we've made a lot of progress because we really understand the biology of tumor immunity and also the biology of immune suppression and the biology of what's happening in the tumor microenvironment. So this is a picture of what pancreas cancer looks like under the microscope, and it's a very interesting cancer in the sense that sometimes up to 80 or 90% of the cells in the tumor aren't cancer cells. And so we've spent the last decade really just asking the very simple question, what are these cells in the microenvironment of pancreatic adenocarcinoma? And are these cells that are in the tumor microenvironment a reason why this is such a virulent and difficult to treat malignancy? So pancreas cancer has a very dense stroma, and any pathologist can tell you that. And there's really an abundance of cells that infiltrate the tumor, but pancreas cancer is different than others because the majority of cells that infiltrate the cancer are actually myeloid cells that are derived from the bone marrow. And you can see here, does this pointer work? The green are granulocytes and the red are monocytes. And so most cancers actually have an infiltrative T cells, but T cells are really the minority in pancreas cancer. And it's these bone marrow derived myeloid cells that make up the majority of the cells in the microenvironment. So it's a really interesting concept when you think about it, especially as a surgeon, is that there's a very active conversation going on between the tumor and the bone marrow, wherein cells from the bone marrow are mobilized, they come into the peripheral blood, and they ultimately make it to the tumor. And when they get to the tumor in pancreas cancer, these myeloid cells act basically as a shield and prevent an effective immune response. And so it's analogous to wound healing. It's the same concept, and with a surgical incision, you have emergency myelopoiesis in the bone marrow. The first thing that comes are the platelets to stop the bleeding. Then you get granulocytes to stop infection. Then you get macrophages in the wound to remodel the wound. And the cancers basically trick the bone marrow into thinking that it's a chronic wound. And so you have this constant influx of cells from the bone marrow that infiltrate the tumor microenvironment. And we've spent a great deal of time studying them. And then I'm going to talk a little bit about the difference between adaptive and innate immunity, because those myeloid cells, those granulocytes and macrophages, come from the innate immune system, which is the part that is less specific. It has limited diversity. It does not have memory, whereas the adaptive or the T cell response is quite different because it has extensive diversity to different antigens, and memory response to antigens can be present as well. So this is a busy slide, but what happens is that you have a balance between immune stimulation and immune suppression. And you can see the tumor cells are here in the middle. And most immune therapies to this point have focused on the stimulation side with T cells, looking at checkpoint inhibitors such as anti-PD-1 or designing the perfect genetically engineered T cell that can recognize a tumor antigen. But on this side of these myeloid cells, these myeloid-derived suppressor cells, or M2 macrophages, and these are very immune suppressive. So if you had the perfect T cell that made it to the tumor microenvironment, it's not going to work there because these myeloid cells or these innate immune cells are going to shut off the immune response. And so we asked ourselves, is there a way to intervene in that and to reverse that immune suppression and to manipulate those innate immune cells to improve a T cell response? So I said that there's a conversation going on between the tumor and the bone marrow, and that's really through chemokine ligand and chemokine receptor interaction. And we can show that the pancreas cancers themselves express CCL2. Now, CCL2 is a ligand that will attract CCR2 expressing monocytes from the bone marrow into the tumor microenvironment. And you can see from this immunohistochemical staining that the tumor cells themselves are expressing these ligands that are attracting the macrophages to the tumor microenvironment. And you can see that when you merge these images, it's the ductal adenocarcinoma cells themselves that are attracting these to the microenvironment. So here's essentially what happens, and you can see these are different. This starts in the bone marrow, goes to the blood, and then to the tumor. They start as these myeloid progenitor cells. We can identify them because they express that receptor, CCR2. They come into the blood, and they're still immature and haven't differentiated yet, but when they get to the tumor, they differentiate into these macrophages. So the tumor is sending a message for them to come. They come from the bone marrow to the blood, infiltrate the tumor, and they basically can really strongly suppress an immune system. So they act like this shield of armor, preventing the tumor from having a T-cell response. And so we can take tumors, and these are tumors from patients, and we can isolate all the cells and see that, as I showed you before, the vast majority of these cells are myeloid cells. The red are monocytes, the green are granulocytes, and the T cells, again, are quite rare. And you can look at multiple patients with pancreatic adenocarcinoma, and you find the same pattern with this heavy predominance of these myeloid cells. So we did a clinical trial, actually, and this was published a couple of years ago, in locally advanced disease, where we used inhibitors of that chemokine receptor axis to prevent those cells from getting out of the bone marrow and getting to the tumor. And what we found in that is that when we did that, we actually improved the response rates in patients with locally advanced pancreas cancer that received FOLFIRINOX. So what you'd expect for a response rate in FOLFIRINOX only is about 30%. And when we added this CCR2 inhibitor preventing the mobilization of these cells from the bone marrow to the tumor, we found that we got a 50% response rate, so better than expected, which increased the enthusiasm for this kind of novel approach to the treatment of pancreas cancer. And if you look at the baseline and after we've given our drug, you can see that you've hit the target, and these tumor-associated macrophages are markedly diminished in patients that got drug. And this is an oral drug, relatively safe, low toxicity profile, and was given in concert with FOLFIRINOX in patients with borderline resectable disease. We went on to do, this is just a representative flow cytometry plot showing that when you look in the tumors, here's before the drug at the top on the right, these macrophages in the tumor microenvironment. After the drug, they're virtually gone, so it's telling that the drug hits the target and prevents the infiltration of these cells into the tumor microenvironment. And then the other thing that we did that was important in this study is that we got from the patients baseline and on-treatment biopsies so we could compare the change before and after treatment. So these patients all had locally advanced disease, so they had endoscopic ultrasound-guided biopsies before treatment and after, and we could compare baseline to post-treatment. And you can see after treatment, the CD8 cells went up, the CD4 cells went up, suggesting that you're taking an immunologically cold tumor and turning it hot, allowing a T-cell response to happen, and regulatory T-cells, which are suppressive, went down in patients that received the drug. So again, suggesting by blocking these macrophages from coming to the tumor, you can turn on an adaptive immune response. So you've got to hit both. You've got to hit the innate side of the immune system as well as the adaptive. You've got to reverse the immune suppression by getting rid of the innate cells, and then you've got to turn on the T-cells and activate them in the tumor microenvironment. There was good evidence from these biopsies that we took from patients that this was happening. And then the other thing that was interesting is that if you looked at the responders and the non-responders, you could definitely correlate the prevalence of these CCR2 positive immature monocytes in the peripheral blood. So in other words, if you were hitting the target and these were decreasing from baseline, that those are the patients that were most likely to respond. So the conclusions of this clinical trial was that this agent, this CCR2 inhibitor, had manageable toxicities. It improved a partial response rate of nearly 50%, which was would be expected to be about 30% with FOLFIRINOX alone. Prevented the mobilization of these cells, and we could show in the tumor that we hit the target, that these macrophages were not present any longer. And so we took this on to bigger studies. This is a different CCR2 inhibitor from a different company, which we did in metastatic disease. The first trial I showed you was in locally advanced disease, and we found, and here's the survival plot in these patients, and so the median survival was not much better than you would expect with FOLFIRINOX alone, but again, what we saw in these patients that the overall survival really correlated with the prevalence of these monocytes in their peripheral blood. So if the monocyte count was low in the peripheral blood, meaning that we prevented the mobilization from the bone marrow, these patients were much more likely to survive. Again, proof of principle that the mechanism was such that it was turning on an immune response. And so we did these 3 trials with 2 different drugs from 2 different companies, from Pfizer and from ChemoCentryx. with different chemotherapy backbones. And we essentially had about a 45 to 50% response rate in these patients. And at 18 months, about 30% of these patients are alive. Now, these are patients with metastatic disease, so you'd expect about somewhere between 15 and 20% to be alive at 18 months with the chemotherapy alone. Another thing that we noted from these biopsies that we took is that when we use the CCR2 inhibitor to block those monocytes, you actually get a compensatory increase in the granulocytes, that other arm of the innate immune system. So this is baseline and post-treatment, and these are CXCR2 positive. So these are the granulocytic monocytes. These go on to differentiate as neutrophils in the tumor, and when you block the macrophages, you have an increase in the neutrophils, and the neutrophils, these tumor-associated neutrophils, are also immune suppressive. And so this is a potential mechanism by which the tumor protects itself from an immune response by upregulating these neutrophils in response to blocking the monocytes. So that, again, showing that most of these cells are either one or the other. So we block these and these went up. So the question is do we need to block them both to really reverse the immune suppression? And so we went on and did that with small molecule inhibitors of both CCR2 and CXCR2, so it's basically dual myeloid blockade. You're getting the monocytes and the granulocytes. And I'm not going to go into the details of this because we published it just a couple of months ago in Gut, but suffice it to say that when you hit both the neutrophils and the monocytes, the immune response was better, the tumors were smaller, and so that's our next strategy in terms of translating this humans, is this dual blockade going after both arms of the myeloid cells, the granulocytes and the macrophages. So the summary of these studies is that we showed improved response rates. We have evidence from the biopsies that we took that there's reprogramming of the tumor microenvironment, and we're turning on an adaptive immune response. There's a compensatory increase in these tumor-associated neutrophils, which could be a mechanism of treatment resistance. So again, it tells you the importance of collecting these specimens, because we were able to show that the prevalence of the monocytes correlated with prognosis. We're able to show that neutrophils went up, so found a mechanism of treatment resistance, and it informs the next study that we want to do. And if you're not collecting these baseline and on-treatment biopsies, you'll never really understand the biology of what's going on. So this further study of dual blockade is currently up and running, and we just got a large grant from the National Institute of Health to do this study with the combined dual blockade. So I talked about the innate immune system and how you have to really reverse that and attack that before you're going to get an immune response. But the next question is what about the adaptive immune response? So the question is, can we also activate adaptive immunity by manipulation of the tumor microenvironment? And the way that we've just chosen to do this is to use radiation. And think of radiation not as a way for local control of tumor, but more as a vaccine to expose tumor antigens and allow T cells to come to the tumor and get activated after radiation. And I'll show you some preclinical data that we're quite excited about in taking this to human translation. So this is what happens if you compare unirradiated to irradiated, and this is a mouse model of pancreas cancer, and you can see after you irradiate, you get an influx of these cells. These are CD8 positive T cells, suggesting that radiation actually causes an inflammation and causes an immune response to happen. And that actually may be the reason. We think of radiation as DNA damage, and that's how it really shrinks tumors, but there's good evidence that radiation, the way radiation works is by eliciting an adaptive immune response, and you can see the change in the CD8 cells that come in. And when you look at these by flow cytometry, this is looking at CD45 Rho, which is a marker of memory T cells. So, and this is granzyme B, which is activation of C cells. So you're not only getting infiltrative T cells after radiation, they're potential memory T cells, and they're activated. So can we use radiation to turn on a memory adaptive immune response? And if you can, that's good news, because you can actually use the turning on the immune system at that tumor, which can ultimately affect other tumors, distant tumors. So taking a local therapy and turning into something that is more like a systemic treatment. So we developed a preclinical model looking at this, and this is just a mouse model with orthotopic implantation of pancreas tumor. We radiate for 4 days, 6 grays of radiation for 4 days. And we do this with a small animal irradiator. You can see this is orthotopic implantation of the tumor in the tail of the mouse pancreas. We put 2 clips there so that on imaging we can identify it. And we can give radiation to these animals pretty similar to what we would do with a human patient with stereotactic radiation and measure them. And because we inject them with bioluminescence imaging, with tumors that have bioluminescence imaging, we can follow these tumors to see the effect of our therapies. So here's what happens when you do this experiment. This is the control with no radiation, and when you radiate the mice, and this is just looking at the bioluminescence, so it's really a measure of the tumor volume. You see that the radiation causes the tumor to shrink, but over time it ultimately grows back. So it slows the growth, but then the tumor ultimately grows back. And when you look at the tumors after radiation, you can see that you do have an increase in these T cells, as I showed you from that picture of immunohistochemistry before in the irradiated mice, suggesting that you are turning on an immune response by the radiation alone. But at day 11, we start to see an influx of these inflammatory monocytes. So it's a normal physiologic response. The T cells come in, you have an adaptive response. The normal physiologic response to an immune activation is to shut it down when you no longer need it, and that's done by these immunosuppressive monocytes. And so it's kind of a double-edged sword where you stimulate these anti-tumor immune cells, but then these monocytes come in and turn it, and so it'll tip the balance from immune stimulation to immune suppression. So again, the question is if we can prevent that, if we can look at that innate immunity, those macrophages that come in and reverse it, can we sustain the immune response and tip it so it's more exciting an immune response rather than shutting one off. So the main hypothesis of this is you've got to target both. These strategies to look just at T cells and checkpoint inhibitors and CAR T cells and things that people have seen success in immune therapies in melanoma are not going to work in pancreas cancer because of this microenvironment that's very suppressive. So we chose to instead of depleting these macrophages, which I'd shown you in the other studies looking at chemokine receptor inhibitors that prevent them from leaving the bone marrow and getting there, we decided to actually let them get there, but then try to reprogram them when they got to the microenvironment. And we used IL-12 to do this because it has pleiotropic effects of not only reprogramming the myeloid cells and making them more immune stimulatory instead of immune suppressive, but it has effects on CD8 cells, CD4 cells, B cells, NK cells. So it has lots of different effects that are going to tip the balance towards an immune response, but it hits both arms. It hits innate and adaptive immunity. And we did this with a technology with small microspheres, so we can encapsulate these microspheres. We can load them with recombinant human IL-12, and then we can inject them into the tumors. And so we did this with our mouse model, and I'll show you some of this data. So basically we radiate them, we inject the intratumoral IL-12. The idea being is that we're going to promote immune stimulation, tip that balance so that we're really having a sustained anti-tumor response that has memory, that's antigen specific, and is not suppressed by the myeloid cells in the microenvironment. So here's what this looks like, is that we, same experiments with the radiation with orthotopic implantation of a pancreas tumor, and on day 10 we inject these IL-12 microspheres or control microspheres and then follow the tumors in those mice. And this is just an example of, we can image these with ultrasound, and then we can inject at day 10 into the tumor with the microspheres. And this is what the tumor curves look like. This is your control with empty microspheres. The tumors continue to grow. When you do the radiation alone, you see the same thing. The tumors shrink, but then they start to grow out. When you do it with the IL-12 alone, it really doesn't have much a dramatic effect. It's similar to radiation, but when you combine the two, all of these mice are cured. And we're looking at long-term cure. We've now followed these out over 160 days, and the mice that got the combination of the radiation and the IL-12 were cured. Here's survival curves looking at this, again, over 120 days, no recurrences. So this was really intriguing to us. We looked at we know that the line that we're using, KCKO, is radiosensitive, so we also looked at a radio-resistant pancreatic cancer cell line, saw the same thing, suggesting that the radiation was turning on an immune response, and those mice were cured as well. And so then that led us to ask, what's the mechanism of this? Is interferon and gamma involved? So we did the same set of experiments, injected the microspheres at day 10, and we looked at this in an interferon gamma knockout mouse. And you can see that when you do it, here's the wild type, the curves I showed you before. We're curing all these mice, and with interferon gamma, the effect goes away. So excellent proof that this is a T-cell mediated immune response. When we looked at the interferon gamma, the cells that were making interferon gamma, this is from the tumor microenvironment, you can see that the mice that got radiation and IL-12 had very high levels of interferon gamma. And then we isolated these cells that were making interferon gamma to see what kind of cells they were. And it turns out the majority of them are the myeloid cells, which makes sense. They're very predominant in the microenvironment, as I told you. And the fact that you're expressing interferon gamma is you're basically reprogramming those suppressive myeloid cells into M1 or macrophages that will help support an immune response instead of turning it off. So the next thing we did was we took these mice that we had cured and then we re-challenged them to really ask the question, is there a memory response that's elicited by this? So we have these mice out now over 60 days and we re-challenged them with metastasis. We did this with a sort of age-old model where you can do a hemisplenectomy injection of the tumor into the spleen, remove that spleen so you don't get local disease there, and then follow these metastases. And so it's a model that's useful for looking at the liver and subsequent metastasis instead of looking at the primary tumor. And you can see that when we did this, all of these mice were cured. So all of the controls got tumor that grew out in the liver, whereas the ones that had been previously treated with the radiation of the microspheres were cured, suggesting that there was a sustained and memory T-cell response in these animals. And so the other thing we did is looked at the abscopal effect, and for that we injected a tumor just in the hindquarter. So in addition to the mice that were cured that we went on to re-challenge, we gave them another tumor in the hindquarter, and we could show that the tumor went away, the primary tumor went away, but also the distal leg tumor went away. That hadn't been treated, hadn't been radiated, again suggesting that you've used the radiation and the microspheres to turn on a systemic response with a local treatment. So in summary, radiation induces both immunostimulatory and immunosuppressive cells in the pancreas microenvironment. When we combine the radiation with the IL-12 microspheres, it elicits this potent anti-tumor response, and all these mice are cured, and they're not only cured, but they're cured to re-challenge. Interferon gamma is required because in interferon gamma knockout mouse, the effect goes away, and CD8 cells are required. I didn't show you that data, but if you do CD8 depletions, you lose the effect as well. So this results in a systemic immunity. A local treatment results in a systemic immunity, and that's because you're attacking both the innate and the adaptive immune response when you do it. So the potential mechanism is this. You repolarize these TAMs, which before were immune suppressive with the interferon gamma. They get reprogrammed to M1 macrophages that will support an immune response, increase the intratumoral CD8s, which become activated. They express granzyme. They have that memory marker, CD45 rho, and then to subsequent re-challenge, we've proven that we've sustained a systemic response, a memory response. So immune cells in the tumor microenvironment suppress anti-tumor immunity, and the myeloid cells predominate in pancreas cancer. Efforts to either eliminate them, which in the first studies we showed you, or to reprogram them are very promising, and novel therapies targeting both innate and adaptive immunity are required in pancreas cancer to turn immunologically cold tumors hot. So this is our group at the Center for Tumor Immunology at the University of Rochester. The IL-12 work was predominantly done by Scott Gerber and Brad Mills. The CCR2 work was done at Washington University when I was on the faculty there. Some of the people that did that work are here in the audience: Dominic Sanford and Marina Pani, Timothy Nywenning. But I just want to thank this team because this was a lot of work. I also want to thank the patients that subjected themselves to these serial biopsies so that we could really understand the biology of what was happening. So I think I'll stop there and open it up to any questions. Thank you.
Thank you, Dr. Linehan, for this very good talk and impressive result, I must say. Are there any questions? Yes, please.
Yeah, Henry Pitt, Temple. David, fantastic work, excellent summary. Almost all of the work on the microenvironment has been done around the fibroblasts, but when you look at human tumors, they are the majority of the cells, and then you have a smaller subset of the cancer cells, and then there's this very little subset of adipocytes. Yeah. You know, Nick Zyromsky and I a decade ago started looking at that, although we never got prolonged funding. And when we looked at the microenvironment in a mouse model, we were surprised to see B cells rather than T cells. Yeah. And almost all of the work has been on T cells as opposed to B cells. Educated me and others a little bit more about any more recent work on adipocytes in the microenvironment, and where do you think B cells play a role in all of this?
Yeah, I mean, so there is, you know, work in pancreas with looking at the B cells and trying to reprogram B cells. The ibrutinib trial that Margaret Tempero is doing at the University of California, San Francisco. The results of that remain to be seen. I think B cells probably are important. And that's one of the things, one of the pleiotropic effects of the IL-12 is that it will actually result in an antibody response from B cells. I think people were skeptical about B cells for pancreas cancer because unless you change that very dense stroma with interstitial pressure, the antibodies aren't going to get into the tumor microenvironment to do what they have to do. That may be different after you reverse the macrophages because you do create space, there's less desmoplasia, there's less interstitial pressure, so the B cells could have a role. In terms of the adipocytes, I don't really know. I remember actually working with Nick, sending him these cell lines to do this. We don't see, they're not very prevalent, but they're present. And so whether they're playing a role, I don't know. But you know, it certainly is a very complex environment. And the other thing that's pretty interesting to me is that all these signals are coming from the tumor themselves. So it's the molecular biology of the tumor that's really orchestrating what's happening in the microenvironment. There's a very interesting paper that came out just a couple weeks ago from Ben Stanger and Bob Vonderheid's group at Penn, showing that if the tumor expresses CXCL1, which is one of these chemokine ligand receptors, the expression level of CXCL1 predicts whether or not there's going to be a T cell infiltrate in the tumor or there isn't. So there's all kinds of signals going on from the tumor that are different from tumor to tumor that are going to decide what exactly that mix of cells are in the microenvironment. But the main thing in pancreas is the monocytes are you know, they're 80% of the cells in there. They're very prevalent. That's why we sort of focused on them and tried to either block them from getting there or manipulate them to augment an immune response. But the adipocytes are interesting, and I haven't talked to Nick in a while about it, but I remember sending him some cells to work on that. But I haven't seen much in the literature since then.
Thank you very much. Was there any comments or question? I have a little bit provocative question for you. Despite all that you show us and the importance of relationship between immune system and pancreatic cancer, what is your opinion, why we don't see good immunotherapy drug coming for pancreas cancer?
I think because the field has been too T-cell centric. It's been focused on the T-cell. And unless you deal with the immune suppression from the monocytes, the T-cell's never going to work. So I don't think that there's any reason why you can't have effective immune therapies in pancreas. You know, part of it is the penetration. You know, if you have a CAR T-cell, which a CAR T-cell is, you know, basically taking an antibody that you know is present, the antigen is present on the tumor, and taking that monoclonal antibody and attaching it to a cytotoxic T cell that can work in the microenvironment, it may not be able to get in there because of the dense stroma. But if you reverse the macrophages, if you deplete the macrophages, then they can get in. So it's just a matter of understanding the biology better. You know, everyone sort of thinks, well, melanoma is an immunogenic tumor. Pancreas has just as many potential immunogens and antigens in it. It's just that it's surrounded itself. It's an immune privilege organ, right? If you have a immune response to your pancreas before insulin was discovered, you didn't survive, and so the pancreas is an immune privilege organ, and so as a result, I think the tumors become immune privileged with this mechanism related to these myeloid cells that shut off an immune response. So it's really understanding biology, and so we just have to keep doing these trials. But I'm pretty confident that we'll have immune therapies that work in pancreas like we do in melanoma and other cancers.
Okay, so in the near future, where are you going to put your money? Are you going to put your money in drug which potentialize chemotherapy or radiotherapy, or pure immuno?
That's a really good question, because I think one of the things we do is when you talk to the medical oncologists, they say we have to use chemotherapy because it works. Well, it really doesn't work that well, let's face it. And you're turning on a T cell response, and then you're giving systemic chemotherapy, which makes everybody neutropenic and wipes out the T cells. And so the question is how do you time that? So one of the things we want to do with this IL-12 microsphere study is patients with locally advanced, it's a perfect study for locally advanced disease because you're injecting it into the tumor. And those patients get 6 months of chemotherapy. Most of them get FOLFIRINOX for 6 months. And after 6 months, they're tired of chemotherapy. They have all the toxicities. Their quality of life is diminished. we know they're all going to ultimately progress and recur, or don't even not recur, they don't get resected because they're still locally advanced. There's a subset that remain locally advanced that don't have systemic disease. That would be the perfect time to put this on the end of chemo as consolidation therapy, where you do the radiation and the microspheres, so without giving chemo. So if you are turning on immune response, you're not turning it off with the chemo. But how to time this therapy with chemo is a really important question. One of the things that I like about that trial is it's doing it as almost like second-line therapy with immunotherapy only. You can really get the biopsies, you can figure out what's going on with the immune response and try to figure out the way to do that right. And second line, I think you can do it. You know, after FOLFIRINOX, patients really don't want more chemotherapy. And if you can do an immune therapy with low toxicity in second line, you can do immuno-oncology trials only without systemic chemotherapy. In first line, it's pretty hard to do because you do have a response rate with FOLFIRINOX. It does prolong survival compared with chemotherapy.
You think the direct injection is better than the systemic?
Well, I think for this particular, in that patient population, I think it is, but there's evidence that this local therapy is turning on a systemic response. So you could even say, well, why not let's do this in metastatic disease? Take one liver met, radiate it, inject it. If you believe what we see in the mouse, then you could be turning on the immune response there, getting those memory T cells and doing that. So you could do it in the metastatic setting as well. But I think locally advanced is a great place to start with this, because after chemo, we've got nothing left to give them. And a lot of patients are still local only and haven't metastasized at that point.
Are you far from transferring your technology to patients?
Not far. We're commercializing it right now, and so we should have that trial open relatively soon. We have to go through the regulatory process through the FDA and things, but 6 months to 12 months probably.
Very exciting. I think, any other questions? If there are no questions, we really thank all three speakers for exciting lectures, and thank you very much.
Thank you.
Have a good day.